method used to give oxygen will depend on their saturations and the presentation of the patient and the work of breathing. So some of the acute conditions include medical emergencies requiring high concentration of oxygen. For example, in cases of shock, sepsis, major trauma, cardiac arrest during resuscitation and post-resuscitation, in anaphylaxis, carbon monoxide and cyanide poisoning, and transfusion-related acute lung injury, and many more. For the chronic indications, we have COPD, cystic fibrosis, pulmonary fibrosis, sarcoidosis. Then we have relative indications where you give oxygen depending on how your patient presents, like in asthma, bronchitis, heart failure or heart failure exacerbations, and pulmonary embolism. There are many other conditions, so you'll go and add. So oxygen saturation, you give oxygen, then you need to target your SpO2 levels. So we normally target between 92% to 98%. This varies. For example, in children, you'll target between 90 to 95%. In neonates, you'll target between 91 to 95%. Post-resuscitation, you'll target between 92 to 98%. For patients with chronic hypercapnic conditions like COPD, then we normally aim for lower oxygen saturation targets, that is between 88 and 92%. So if you give higher oxygen levels, then you might hinder with the hypoxic drive in the chronic, in patients with chronic conditions. So also oxygen therapy is indicated when saturation levels normally drop below the threshold, and it normally helps prevent the risk of hypoxemia and to avoid complications of your patient. However, there are contraindications and risks involved with oxygen therapy. For example, in patients with paraquat poisoning, which is normally found in herbicides, if you give oxygen, then you can exacerbate the toxicity due to the redox activity of the oxygen. So it's normally contraindicated in paraquat poisoning. As I had said earlier, patients with COPD, if you give them a lot of oxygen, you might reduce their respiratory drive, and this will lead to further hypercapnia, altered mental status, and respiratory failure. So you normally give oxygen in moderation for patients with COPDs. When you give neonates oxygen, you need to monitor the SpO2 levels because elevated oxygen levels can lead to retinopathy of prematurity, and we also have those complications of excess oxygen use in pediatrics. Also, you need to moisturize your oxygen, because if you give dry, high flow oxygen, then you can increase fluid loss via insensible fluid losses. Also, high levels of FiO2 can lead to oxygen toxicity because the oxygen will be broken down to the free oxygen radicals in the body, which normally are toxic to human tissues and will cause inflammation and worsen the condition of your patient. So you need to give FiO2s that are required and are that your patient needs, not to give excess. While giving oxygen, you need to monitor it continuously so that you can avoid the complications which normally come from oxygen therapy that we have discussed. We have administration modalities where you have low flow administration and high flow. And a low flow, we normally use devices like nasal cannulas, transtracheal catheters, face masks, and the nasal cannula will normally deliver 2 to 6 liters per minute of oxygen. And it's normally good because your patient can communicate, they can walk with it. Yeah, you can also give transtracheal catheter, which is normally inserted in the neck, and it's for direct oxygen delivery. It bypasses the upper airway. Therefore, the amount of oxygen used is less compared to other modalities, and it's effective. And a face mask, we have simple face mask, we have non-rebreather mask, and we have a Venturi mask. Simple face mask can give up to 5 to 10 liters per minute of oxygen. It normally covers the nose and mouth. The non-rebreather mask will normally give 10 to 15 liters for all ages in pediatrics and adults. A simple face mask is not used in the pediatric population, especially the small children. And then you can have a Venturi mask, which uses jet mixing, and it allows for controlled oxygen delivery. It delivers up to 40%. The non-rebreather mask has a reservoir bag that normally stores 100% oxygen and enhances the oxygen concentration. For the high flow administration, you have a high flow nasal cannula that can deliver up to 100% FiO2. And with it, the patients can talk, eat while receiving oxygen. And it normally supports apnea before intubation. We have positive pressure, where you have CPAP, that is continuous positive airway pressure. And it normally keeps the alveoli open because of the positive pressure. Then we have a BiPAP, that is bilevel positive airway pressure. It delivers pressures under different settings, and we had discussed and said BiPAP is normally used in patients who can normally support their airway. So it's adjusted depending on whether your patient can support their airway or not. We have a bag valve mask. This is normally used especially during resuscitation, and we all know how to use it. And it's normally connected to high flow oxygen therapy, and you'll administer oxygen depending on your patient's needs. We have a ventilator, which can be given through endotracheal tube or tracheostomy, and the oxygen level will be adjusted depending on the needs of your patient. And the last modality is neonatal incubators, where oxygen is administered within a controlled chamber for neonatal care without the oxygen being applied on the patient directly. That's the overview. So you're going to discuss respiratory acidosis and alkalosis. We will start with acidosis. That's an image depicting about respiratory acidosis. And I would like to say acidosis is where you have low pH in blood, which is acidic, where the pH is less than 7.35. And respiratory, it shows that it's because of the failure of the respiratory system. We had discussed about how oxygen and gaseous exchange occurs in the body. We said when you breathe in, you inhale oxygen, which normally goes to the alveolar and crosses to the capillaries, is transported to the tissues by blood, and then carbon dioxide is produced by the tissues after metabolism and transported back to the lungs and expelled to the environment. So when you have damage or a break in that system, such that, for example, the CO2 that is being produced is not being excreted, then you end up having with excess CO2 in the blood, hence alkalosis. And excretion of the CO2 will normally depend on many things. For example, when you have excess CO2 in the blood, the carotid sensors, the barometers in the carotid, will normally detect that there is excess CO2 and will send a signal to the respiratory centers, and the respiratory centers will inform the lungs to breathe out more so that you can excrete CO2. So there are many things that can cause injury or damage to that system, and end up having accumulation of CO2 in the blood, hence having respiratory acidosis. Also, I would like to say that when you have CO2 in the blood, CO2 will normally combine with water to form carbonic acid, which is normally then broken down to bicarbonate and hydrogen ions. When you have excess of the hydrogen ions, you end up having acidosis. Your patient will present with lethargy, muscle twitching, tremors, convulsions, and coma. This diagram also illustrates how the causes of respiratory acidosis. For example, you have pneumonia, which leads to inflammation of the capillary alveoli barrier, and you end up having edema. Therefore, CO2 cannot cross to the alveoli effectively for it to be expelled. You have pulmonary edema, which the mechanism of action is the same as pneumonia. You have emphysema and bronchitis. In this condition, you'll find your patient is hyperventilating because the problem is not with the respiratory centers. It's the problem is in the alveolar capillary barrier, where there is no adequate diffusion of CO2 from the blood to the alveoli. You'll find your patient can have hypoventilation, for example, in oversedation. Therefore, they cannot expel the CO2 adequately. Same applies to brainstem trauma and immobility and respiratory muscle paralysis. As we had said, you have acute respiratory acidosis and chronic respiratory acidosis. In acute, there is sudden rise of partial pressure of CO2 due to ventilation failure, and the conditions include such as cerebrovascular accidents, when you use CNS depressants like opioids, failure of respiratory muscle dysfunction like in myasthenia gravis, muscular dystrophy, and Guillain-Barré syndrome. The compensation is normally slight, and it normally begins minutes after onset due to the acute nature. In chronic respiratory acidosis, you have persistent ventilation impairment leading to sustained PCO2 elevation. Common triggers include COPD, which reduces the sensitivity to hypoxia and hypercapnia. You can also have diaphragm failure from muscle disorders, obesity, hypoventilation syndrome, amyotropic lateral sclerosis, and severe thoracic skeletal abnormalities. Compensation is due to, you normally have renal adaptation, which normally occur over several days. You can have acute on chronic respiratory acidosis, which is normally due to acute exacerbations in patients with chronic respiratory disease. For example, like pneumonia or disease exacerbation that causes ventilation perfusion mismatch. It's normally, the compensation is complex because there is normally compensation due to the chronic nature. Then with the disease exacerbation occurring, it's like you're adding an acute event on an already compensated state. So when you have respiratory acidosis, you'll have some biochemical effects, like in ions, there'll be increased calcium, ionized calcium and potassium, though hyperkalemia will normally be mild. In chronic adaptation, there's gradual renal compensation, which will align with the chronic cases. This will normally go back to equation. Now we said CO2 will combine with water to form carbonic acid. Carbonic acid is broken down to bicarbonate and hydrogen ions. So the hydrogen ions will be excreted in the kidney, and bicarbonate will be retained so that the pH can stabilize. So in chronic adaptation, you normally find compensation, which occurs by excessive excretion of hydrogen ions via the kidney. Just a recap of the pathophysiology. We said carbon dioxide is normally produced after metabolism in the body, and it's important for pH regulation. It normally serves as the primary driver of ventilation, and this occurs where the baroreceptors in the carotid will detect if the CO2 is high or low, and will command the respiratory centers to either increase hyperventilation or to reduce ventilation. So if CO2 is a lot, then the respiratory centers increase ventilation to excrete the CO2. Normally the CO2 levels are kept between 38 to 42 millimeters of mercury, and this is normally balanced through respiration, as I have said. The CO2 and pH balance. So if you have hypoventilation, CO2 production exceeds the elimination, causing CO2 retention. Therefore, CO2 will shift in the equation of the carbonic acid bicarbonate system, which is normally shown below. We have the carbon dioxide buffer system, where you have CO2 plus water to form carbonic acid, which is broken to bicarbonate and hydrogen ions, and the hydrogen ions are excreted into the kidney, as we had said. So the bicarbonate and carbonic acid normally remain in equilibrium, with bicarbonate will neutralize excess hydrogen ions in low pH conditions, while carbonic acid will neutralize hydroxyl ions in high pH conditions. So in respiratory acidosis, there is increase in CO2, leading to an increase in bicarbonate and
Basement. Unakuanga bundles mingi aje? Zinakuanga mingi.
will normally cause an overall pH decrease, leading to acidosis. This buffering will normally help the body resist the extreme changes in pH, although with prolonged CO2 retention, you end up still having the low pH, which will be seen in respiratory acidosis. So your patients will present with various symptoms, and that will depend on the cause, duration, and how long and progression of the illness. They'll present with dyspnea, anxiety, wheezing, and sleep disturbances. You can see cyanosis. In severe, strong, or prolonged hypoventilation, you can have altered mental status, myoclonus, seizures, cerebral vasodilation, increased intracranial pressure, and papilledema. Chronic cases you may see memory loss, impaired coordination, polycythemia, pulmonary hypertension, and heart failure. Persistent apnea will result to daytime somnolence and headache. And it's normally important to identify the underlying cause, because you need to correct the underlying cause so that you can correct the acidosis and prevent it from getting worse. Differential diagnosis of respiratory acidosis include botulism, bronchitis, diaphragmatic disorders, diaphragmatic paralysis, asthma, opioid use, sedatives, hypnotics, anxiolytics use disorder, COPD, and obesity.
I bought her a chocolate.
So when you meet your patient, the investigations you'll order for include
Can you please take me clean your teeth in December? Nitakupeleka hapa Luton. Luton? They have a dentist. Sasa hii napata faida mingi. Sasa hii niko faida mingi. For me, I'll just pay for you. I can pay for you. They'll give me a subsidized rate. Why can't it be people? I'll go to the You're dependent on me. You're my dependent.
bicarbonate will rise by 4 millimoles per liter for every 10 millimeters of mercury increase in PCO2. This will be over days, and acute it's normally over minutes, as we had discussed. If the compensatory mechanisms don't align with the patterns that is seen in acute and chronic, you need to consider a mixed respiratory metabolic disorder. You also need to do a toxicology screen to rule out, in cases of unexplained respiratory acidosis, rule out drugs,
my window is open.
overdose. You need to, for the treatment, you need to address the underlying cause. That is what is going to resolve the hypercapnia. Remember, we said hypercapnia is not a diagnosis, but it's a symptom of something going on. You need to correct hypercapnia slowly to avoid alkalinization of the CSF, which can lead to seizures. For pharmacologic therapy, you can consider bronchodilators, like beta agonists, anticholinergic drugs, and methylxanthines for obstructive airway diseases. Give naloxone for opioid overdose. That's all about respiratory acidosis. We are going to go through respiratory alkalosis, and we still go back to the pathophysiology of breathing, where we said you take in oxygen is used by tissues, CO2 is produced and excreted in the through the lungs to the environment. So when you have excessive excretion of CO2, you end up having reduced CO2 levels in blood. Hence, with less CO2, you end up having less bicarbonate and less hydrogen ions, and you end up having alkalinization of the blood. The fact that it's called respiratory, it shows that there's failure in the respiratory system. Causes include head injury or stroke, conditions like hyperthyroidism, where there's increased hyperventilation. You have anxiety hyperventilation syndrome like pain, fear, or stress. And you have drugs like salicylates and exposure to toxins. The causes of respiratory alkalosis, you have hypoxemic causes. Remember we said in hypoxia, there's normally a compensatory mechanism where there is increased hyperventilation in an attempt of the body to take in more oxygen. But in the same time, then you end up losing excess CO2. So you can have hypoxemic causes, which end up reducing CO2 levels. You have pulmonary causes, when you have conditions like pulmonary embolism, pneumothorax, pneumonia, acute asthmatic exacerbations, or COPD. You can also have iatrogenic causes where you overventilate your patient who's on mechanical ventilation. You can have acute respiratory alkalosis and chronic. In acute, there is sudden drop of CO2 due to rapid hyperventilation. The bicarbonate levels are high, and they are typically because the kidney has not yet adjusted by causing excretion of bicarbonate. So you'll see pH of more than 4.5 and so you'll normally find low to normal levels of bicarbonate and pH that is more than 7.45. This compensation in the kidney normally occurs over several days, and while the CO2 level changes occur over minutes. That's how you differentiate between acute and chronic. In acute, there is high bicarbonate and high pH. In chronic, there is normal to low bicarbonate and high pH. Clinical features, you normally see hyperventilation-related shortness of breath. The symptoms include dyspnea, chills, edema, confusion, lightheadedness, chest pain, wheezing, hemoptysis, and neurological signs like paresthesia and numbness. When you do physical examination, you may find tachycardia, tachypnea, diaphoresis, hypotension or hypertension, cough, wheezing, rales, cardiac murmurs or arrhythmias, jugular venous distension, and focal neurological signs like Trousseau's signs and Vostek's sign. The findings will normally depend on the underlying cause majorly. So they are not the same in all patients. How you investigate, you need to do your arterial blood gas to know the pH levels and bicarbonate levels. You need to do your electrolytes, the sodium, potassium, calcium, magnesium, and phosphate. You can do the alveolar arterial oxygen gradient. This will normally differentiate the patient, especially the hypoxic patient. And we talked about it last week with Daktari. And then you can do imaging, chest X-ray for anatomical and infectious diseases, a chest CT scan if is needed, depending on how your patient presents. If you have neurological signs, you can order for a CT scan or an MRI or a lumbar puncture, depending on how your patient presents. For the treatment, you still have to treat the underlying cause. If your patient has anxiety-induced hyperventilation, then you give anxiolytics. If you have infections, you give antibiotics, and that should be based on cultures. You can anticoagulate in embolic diseases. You adjust the ventilator settings if you are overventilating your patients. And you can use acidic agents, which are rarely used to lower pH, but may be considered in severe cases. Those are my references for the topics covered under this unit. And thank you so much. That's all for my presentation. We'll have Daktari taking us through respiratory failure. Thank you. Any questions, additions? They are welcome. The floor is open. If there is no questions or comments, I think we can go to the next presenter.
Maybe, sorry, just before Muli can present. So I just wanted to thank you, Melima, for the presentation that you did. So I just wanted to say that your presentation was very well done, and I think a lot of us can pick from your presentation for subsequent presentation in terms of thoroughness. So that's what I wanted to say. Yeah, and I really appreciate the fact that you went above and beyond to cover the topic extensively for us. And I know things will start making more sense as we keep doing the topics as we go, and we'll actually get to tie everything together at the end when we finish doing the respiratory system, pathophysiology, and management. So thank you very much for your thorough presentation. Yeah, it was quite comprehensive, and I just want to say that I've personally gained a lot. Yeah, that's what I wanted to say.
Thank you so much.
Muli, we are kindly waiting for you to share your screen so that you can present for us.
Hi everyone. Just a kind request to Dr. Nelima. Maybe she can share her slides before Dr. Muli starts his presentation.
Yes, I will share them.